Happy Wednesday. Welcome to episode 191 of the 988 Crisis Jam, Warmlines and peer support lines as allies. We're going to hear a wonderful feature presentation from Howard Treckman. But let's get into this jam before we go to the feature presentation. We've got our standard segments here. First one is talk.crisisnow.com. Please make sure you favorite that because that website is going to give you everything you need to know about this learning community that you all have helped us grow. You can register for the jam, and we've got two new virtual backgrounds with 988. So you will no longer be using the old logo like I am doing, but you will have the new background. So go to the website, download it, and then you can see the highlights from recent jams, right? Last week was Dr. Ryan Combs and Angela Roberts talking about marketing for LGBTQ plus and African American populations we know are at high risk. So please do check it out. Talk.crisisnow.com. So we also have our news segments, right? And so this news story, which will be a link will be dropped in the chat, comes to us from the Gwinnett Daily Post. And it's retirees are in a mental health crisis. These are the states where seniors are most at risk. So if you have a senior or older adult in your life or someone who is seasoned but not spicy, make sure you check these out and make sure that you, again, work with officials in those states to say, how can we better support our seniors or anyone who is at risk of being in a mental health crisis? And then our other news story comes to us from the Manchester Mirror. Michigan's mental health crisis extends beyond students. Teachers struggle too. This is, again, so important because we know different populations are at high risk. And so we've done, we focused a lot on youth, and we still need to focus on youth because they're at particular high risk, but we also need to make sure we're supporting those who provide support and care, and that includes teachers. So a really interesting article linked in the chat there. And then this one's from the Bronx. News 12, Brentwood opens facility to help mothers with prior convictions reconnect with their children. Again, as we talk about reentry, ensuring that folks can come back into society, making sure that we're supporting those people who are re-entering, but as well as supporting their families. And so this sounds like an amazing opportunity. So that is also linked into the chat as well. Lots of news going on, guys. So in case we've missed anything, make sure that you put your link to any article in the chat as well. We want to keep notes and tabs on those. So we've got our lived experience library. I actually might need a little help on this one. But I know the crew here that makes the Crisis Jam happen put together amazing resources. And so there are lots of things available at the Lived Experience Library. Link is in the chat so that you can see more about that. And again, if you've got suggestions for books, articles, please throw them in the chat, or you can email crisisjam@crisisnow.com. All right, guys. So we are at the point where we do our crisis trivia hot seat. Now, traditionally, how it's done, there is a person who has volunteered to be in the hot seat, and that volunteer has the opportunity to win a branded Crisis Jam 988 hat, t-shirt. We've got lots of options. We do not have a volunteer for this week. So before I put this open to the entire chat, to all the entire Crisis Jammers, please raise your hand if you would like to volunteer to be a brave soul to come into the hot seat. And I'm going to just take a look. And if you do raise your hand, we will spotlight you. But I'm going to give you maybe about 10 more seconds to be brave, get your shirt, get your hat. Any takers?
We've got a few.
We've got a few. Okay, I can't see them. Will you just spotlight whoever was first? I'm sorry, I can't see you.
Okay, Jessica, I believe you were first. I will spotlight you right now.
Okay, Jessica, welcome to the Crisis Jam. Please tell us who you are, just briefly. Uh,
Hi. I work for Access Living. I'm the mental health policy analyst there. And I come almost every week because we wrote a bill called CESA, which is directly relevant to the what we learn at the Crisis Jam.
Awesome. Well, Jessica, I know you're going to do well as a fellow policy person. I know that you're going to knock this out of the park. But again, you also have assistance from the audience. So here's the hot seat question for this week, and it's about Warmlines. So Warmlines began to gain recognition in the 1990s as a mental health service. They've met the need of support services that were not solely crisis based. So based on what we know about Warmlines, um, which of the following best describes the key differences between behavioral health warm lines and crisis lines? Is it A, funding sources, B, service hours, C, staff qualifications, or D, intended use cases? And again,
Oh,
it's what is best describes.
I I'm gonna guess D.
Okay, I cannot. Do we have
Oh,
the
me vote.
results posted? I can't see those as well. Let's see. I think most of the audience, I will at least say, yep, most of the audience. We've got 55% saying D. Do you want to make that your final answer?
Yes, I'll make it my final answer.
All right, let's see if we've got the majority of the audience with you, Jessica. The primary distinction between warm lines and crisis line is, in fact, D. I knew you were going to do it. Yay.
Thank you.
You will get some branded merch. Folks will reach out to you to let you know. But again, there may be other differences, but the D is the best out of those four to describe the distinction. And as it notes here, it is the primary distinction is intended for situations to address. Warm lines are for where the caller could benefit from someone to listen, provide support, and connect them to appropriate resources. So um, very exciting. Thank you for participating, Jessica, and being brave. Um, with that, I will turn it over to Howard Trackman, who is the executive director of warmline.org, to do our feature presentation.
Thank you very much. Today's presentation is Warmlines in Action, Strengthening Mental Health Through Connection. Next slide. I founded Warmline.org in 1999. I'm a mental health advocate. I'm a certified peer specialist. I'm a certified older adult peer specialist and a certified psychiatric rehabilitation practitioner. You can see I've been on a number of boards and committees, usually serving as chair, co-chair, or as president. Next slide. This is me in June in Denver at the NAMI convention, being given a Lifetime Achievement Award. The Kiva Centers also gave me a Lifetime Achievement Award. I've gotten over 10 awards as well, including 3 national awards from NAMI and PRA. Next slide. Next slide, please. So I received my services from the Edinburgh Center, side effect of being in the state hospital for 9 months in 1985. We approached Departmental Health in 1999 to fund and start the Edinburgh Center Warmline, and is still in existence today. I'm the co-founder of the Metro Boston and Southeast Recovery Learning Communities. And when we bid on our contract in 2008, we wanted a peer support line, a warm line. We have it, and it's still in existence today, open 7 days a week from 4 to 8 p.m. Next slide. What is a warm line, you ask? So this is new to many of you. Some of you, hopefully it's not. Next slide. The uniqueness of warm lines is that they're peer support lines. They're all staffed by peer specialists, interviews, living with lived experience in recovery. Recovery can be defined as from a variety and or a combination of issues. and we save money for both people and government systems by reducing hospitalizations and other levels of care. We've been researched by Dr. Galton from Pennsylvania, and you'll see some of that research shortly. We bridge the gap between services. We divert people from more expensive services. Most Warmlines are trauma informed and maintain anonymity to a higher degree than a suicide hotline, and we do not share information with police. Next slide. This is a popular saying I've been saying for a while. All Warlines developed organically with different types of funding sources and trainings and whatnot, and their style and how they answer questions and how long they'll let callers call. So if you've called one warm line, you've called one warm line. No two warm lines are the same. Question in the chat. There are a number of states that don't have warm lines. Most states do. Warmline.org provides a directory service to all the warm lines in the country, and it's searchable by state, hours, and language spoken. Warmline.org is your best option, and we'll have that slide up later. Thank you. Next slide. Warmline services developed originally telephonic, that you would call them over the phone and talk with a peer specialist. Some Warmlines will call people back if they leave messages. Some you need to connect somebody live. Some Warmlines have a rapport with their frequent callers, and some of them do call outs and reach out to people at regular times. But as technology has been advancing, more Warmlines are utilizing text chat and virtual and Zoom type meetings. Next slide. Different types of support offered: emotional resources, isolation, community, safe space, judgment-free. There's really no wrong reason to call a Warmline. Some people call it because they're lonely, or they're having a hard time, or they're looking for resources, or they're in a crisis. People choose to call Warmlines instead of crisis services in many cases because of the type of call support they get from peer specialists and not wanting to be sectioned or involuntarily hospitalized. Next slide. Data shows the effectiveness and accessibility of Warmlines through Dr. Duggan's research. Warmline callers reported being more optimistic about their future and believe personal goals are achievable. While the majority of Warmlines take 350 to 6,000 calls annually, there are Warmlines that take over 45,000 calls annually. A lot of it has to do with the demographics of the state and the funding, and we do have Warlines that serve diverse populations. Thank you very much. Next slide. Okay, here's some really good data from Dr. Duggan. Warmline participants were asked if they thought that using a Warmline reduced their need for crisis services. They'll say that over half of the people consistently over 4 years said that was very likely. Over a quarter said that was somewhat likely, and only a few said very unlikely. Next slide. In addition to the quantitative data, we took qualitative data. Number of respondents commented that they used to call crisis almost every night, now hardly ever, that they would turn to Warmline before crisis, and having called crisis, use it less and less. Next slide, more data, qualitative data. You'll see about 3/4 of people reported discussing coping strategies, reported Warmlines contribute to their own personal recovery process. About 2/3 said they reported feeling better after, or reported an increased sense of personal empowerment, or reported access to Warmline support increased their sense of well-being. And almost everybody said they reported likely or very likely to call again, being very satisfied or satisfied with the service. We're very happy with those metrics. Very good numbers. Thank you very much. Next slide. Again, some comments people made about what they found most helpful. Someone to talk to, a person who can relate and truly understand. Peer support staff is well trained and quality listeners, and non-clinical,
Howard, you accidentally mute it yourself.
Okay, what callers found helpful, someone to talk to, a person who can relate and truly understand, personal support staff is well trained, and quality listeners and non-clinical, non-provider staff. Next slide. Not everybody found the Warmlines helpful. Difficult to access, you know, limited hours at some Warmlines, not enough time to talk as somebody might like. Requests were made late at night when there's few Warmlines that are open. Also unable to connect with the peer specialist for a variety of reasons. Maybe just not a good fit. Maybe there's an age mismatch, couldn't relate, didn't find the operator respectful, or didn't get the resources they were looking for. So that does happen. Next slide. Challenges right now, there's some efforts to do this, but right now there's a lack of an centralized hub to share resources, trading materials, best practices, and technology across Warmlines across the country. Funding and sustainability is always an issue. We do have Warmlines that have lost their funding and had to close down. And training and retention of workers is very essential, and many times people aren't paid a huge salary and there's significant turnover. Next slide. Muted again, I don't know. Call to action. We're hoping that you'll come away from this presentation learning more about Warmlines and trying to support us. We're hoping that you will support your local Warmlines, spread the awareness of Warmlines, let your callers know about them, collaborate with Warmlines for funding and finding resources and solutions. We dream for the day where there's a 3-digit number for peer support lines, and to use warmline.org as a resource to find Warmlines in their area or other areas that might be good for them to call. We recently started tracking our callers. In the last few months, we've had over 115,000 visitors. So we know a lot of people are utilizing our service. Next slide. Where do we go from here? We're still developing warmline.org. Our intention is to become a resource for both Warmline callers and service providers, helping develop a go-to hub of accessible organizational best practices, helping new Warmlines with funding and training strategies, and advocacy for greater public awareness of Warmlines, including working with government to create new funding. Next slide. This is the Warmline Executive Committee that meets regularly to advise me on this process. I am the founder of it. Kim Harrell, who you'll be hearing from shortly, is a founding member, and she's been utilizing Warmlines for herself as well, and you'll be hearing from her shortly. Dr. Rebecca Daligan is our researcher. She's done significant research on Warmlines over the years. You'll find that on warmline.org. Paul Klemeric is a founder of the executive team, as is Ansh, Orly, Trenda, Vanessa, and Ayush. I'm privileged to have in the roundtable Trenda Hedges. She has run the Illinois line for many years and has a great perspective on Warmlines that you'll be hearing from shortly. Next slide. Okay, we thank you for attending our presentation. That is my email address and our website. We'll leave that up for a little bit. Be able to take it down. Kind of covered what I wanted to cover. We're very excited to have a very good roundtable with Kim Harrell and Brenda Hedges. Here are some more references to the research on our website again. And the PowerPoint will be posted to the Crisis Jam website in the future. Raina, I'm looking at your comment there. Hold on. Okay. Thank you. I'll turn it over to the roundtable.
Thanks, Howard. Very informative presentation, and appreciated that you included information on where to find the references. So at this point, I'm going to bring in Kimberly Harrell and Trenda Hedges to reflect on the presentation and to share any information that you'd like as well.
Trent, do you want to go first?
Sure, I can jump in. Absolutely. Thanks, Kim. And thanks, Howard. It's always an honor to work with you. Appreciate all that you do for warmline.org. So my experience in the field of peer support began on a warm line, and I stayed on that same warm line for 15 years. We built it, we watched it evolve, and I have story after story of how warm lines have saved lives. I've also had the opportunity to contribute to multiple warm lines across the United States and to learn with some of the most amazing peers in the National Coalition of Warmline Leaders, the National Peer Support Warmline Council, and the Warmline Listeners International Collective. Some of these folks are on this webinar, and I encourage them to put their info and their perspectives in the chat. So warmlines don't start with the assumption that something's wrong. They operate on the premise of choice and empower self-determination. Nobody is defining crisis for another person or secretly performing assessments. The support that people get through Warmlines is guided by a mutual and reciprocal framework that intentionally reduces power differentials. The peers who work on Warmlines are transparent, honest, and direct, and they demonstrate core values of peer support. So we hear a lot about incorporating lived experience within crisis lines, and that's wonderful, right? Because it informs and it influences, but crisis lines operate from a crisis model. Warm lines operate from a peer model. This model has its roots in social justice and is known for pushing back against traditional medical models to create other options for people experiencing systemic oppression. So warm lines are different. They are meant to be different. They are not meant to be co-opted into crisis models and 988 centers. The leadership and team members of many warm lines identify with the consumer survivor ex-patient movement and strive to move beyond traditional understandings of crisis, disease models, and diagnoses. We create spaces for people to reclaim their power and resist replication of harmful processes like carceral interventions. Warm lines center the voices of the people who call. Supporters validate the caller's experiences and recognize that they may have experienced harm through other forms of crisis support. This is important because there is a whole people group who will never call 988. They are choosing to receive their crisis support through warm lines. The warm lines provide a valuable form of support, peer support. This support is needed and it has been researched and proven effective. Warmline caller surveys have consistently demonstrated that the support provided helps the caller to avert a crisis and take control of their own wellness. These outcomes, though, they are only effective if Warmlines operate under that peer support model. We believe that Warmlines should be peer-run and peer-led. When Warmlines are operated by parent companies and MCOs, the outcomes are diminished and the peer values are compromised. As more Warmlines begin to collaborate in crisis spaces like this, we need to continue to advocate to maintain the fidelity of the Warmline model. We also need 988 call centers to begin collecting data on the number of calls that are being transferred to warm lines. So as Howard left you with some call to action, I'm going to leave you with a call to action and just challenge Vibrant and all 988 call centers to capture this data and share it broadly so we can see a clear picture of the value of warm lines. Thank you. Kim, you want to jump in?
Sure. Yeah, my voice is okay. Hi, my name is Kimberly Harrell. I want to talk about my experience calling warm lines. I always feel better after talking to somebody on a warm line. Mostly I talk and they listen. They offer empathy and support. Although I know Warmlines existed, I never used them myself until after I was a Warmline operator for over a year. Realizing that I could literally talk about anything made me more comfortable calling a Warmline myself. And now I find myself often calling Warmlines. It's a great help to me. I've had a really hard year, and it's been one of my supports that I rely on. When I call a Warmline, I feel heard and understood. I find comfort in talking to a peer who has had their own struggles. The Warmline operators are non-judgmental, and I don't feel like I'm being evaluated. It makes me feel that I am part of a community of peers that is always there for me when I need help. That covers my main topics about using Warmlines. So I want to leave a lot of time for questions. I want to hear what people have to think and answer questions.
Yeah, well, thank you, Kimberly and Trenda, for sharing your experiences and your reflections and your thoughts, and you as well, Howard. You know, it's so important. As I mentioned at the top, the theme of this episode is warm minds and peer support are allies, and so it's so important that people get the help wherever they can, and again, care that feels like care. So whether it's 988 or Warmline, we've got some questions or at least some comments in the chat. We've got really great kudos and shout outs. So thank you all for that. Folks are sharing other warm lines. And it looks like we have here just a comment around Trenda. You did such a great job illustrating how the sector is seeking language to differentiate the real and foundational differences between clinical disease crisis, medical model, and peer support. And peer values-based model. So thank you. Yeah. Again, lots of kudos. If anyone has any questions for our roundtable, feel free to put those in the chat. If there are other Warmline services that you all may be aware of, please put them in the chat.
Can I ask a question?
Sure, go ahead.
Yeah, my experience of being uneasy about calling Warmlines until I really found out, what they were all about by being an operator on a Warmline. I'm just wondering if anyone else has that experience. I know a lot of my peers would never call, and I encourage everybody, to call Warmlines whenever they want to. I think it's probably something we'll need to work on, informing the public that it exists and what it's about. I think it can be used for a lot of filling in the gaps in our system to help people with mental health issues, especially that we've proven that it does help. It's always helped me every time I called. And I wonder if anyone else has personal experience or knowledge about how to get somebody interested to call a Warmline that hasn't before.
Yeah, well, I think that's a great question. And please, if anyone would like to respond, please put that in the chat. We also have a comment or a question that I should say that I'd like to put to all three of you, actually, if I could bring Howard into the conversation as well. And this one, the question is, what a service matching callers who could take a quick survey on gender, ACEs, trauma, which would be directed to a peer, would that be most relatable, or is that overkill? So, again, I think the question is, if we were to try to match someone to what their trauma experience may be, or a gender match to a peer support, is that actually helpful or relatable?
It's an interesting idea, and it does have some merit, but traditionally Warmlines have been what you get is what you get, and different Warmlines are different because sometimes people request a specific caller or a certain person with a gender, and different Warmlines handle that differently. The majority of them do not do that. But I could envision if there was a national Warmline number there'd be a way of trying to get the best possible match for a caller. But most Warmlines are pretty busy all the time and can't easily accommodate that right now. But I'd like to hear.
I'd love to jump in on that. I'm sorry, Howard. I'd love to jump in on that answer as well, because I think that, yes, that would be true peer support, right? Peer-to-peer with experiences that are very similar and comparable. However, without some type of national funding source or some type of consistency across the country, that is going to be extremely difficult for some Warmlines to actually put into practice. There's just not enough funding and not enough staffing to be able to do that true peer-to-peer matching that would benefit that peer support model. So I think it's a great question, Jerry. And I think we need more money to do that. We need more funding.
I think that tees up nicely the next question that came in. And how are Warmlines primarily funded? Does it vary significantly from Warmline to Warmline?
Indeed. Some of them at the state level, county level, or managed care. They're all a little bit different, some through grants. Linda?
Yeah, I agree, Howard. Some of them are funded by state contracts, some are funded through county initiatives, some literally operate on donations and private funding sources. And there's not one consistent source of funding for Warmlines across the United States. All that funding is just coming from a variety of places. Some are from 708 boards, some are funded through National Alliance for Mental Illness, NAMI, some are funded through other organizations, and then again, in-kind donations. So there is not one source of funding.
I'd also like to mention the Warmline I worked on that Howard started at Edinburgh Center. The supervisor there has been volunteering for over 30 years. She's pretty much available 7 days a week, especially during the hours of the Warmline. And so there's literally no funding. Everything is volunteer. So some Warmlines don't have any money and, don't even know how to find money. So that's something we'd like to promote, helping Warmlines finding money.
Yeah, I think funding is always a contentious issue. So just a couple more comments and questions. I think that the idea of the matching service has spurred some comments here. And so just to comment that the goal of peer support is not to create a mentor-sponsor relationship, which is a common misunderstanding. Thank you for sharing that with us. Another question around special services, like options for LGBTQ plus identifying individuals, veterans, Native Americans. Do Warmlines ask callers for such preferences? Are there an options to say, hey, I'm and part of the veteran community, can I talk to a veteran? Are there options for that or specialized training?
I see Howard nodding his head, but not saying anything. So I'm going to just jump right in and answer with what I know about that. And so some Warmlines do offer some of those options, particularly gender transfer requests. There are also other lines that really operate from more of those identity perspectives. So you have LGBTQ plus support lines. There's several options to choose from in the LGBTQ community that do provide that peer-to-peer support. You have Vet for Warriors, which is a veterans peer support line. And then there's also Black Line, and the Black Line is specific to African American or Black Indigenous people of color. So definitely there are options out there, but each individual Warmline is going to have their own policies and protocols for how to respond to those requests. And it's going to be based on the level of staffing that they have which again is based on their funding.
Awesome. Thank you for that. Looks like there's a suggestion for crisistrends.org site to view data. And another comment here from that there are nationwide programs that do not identify as Warmlines, but use peer support and non-clinical models as some of those that you just mentioned, Trenda. So thank you for that. Again, as we said at the top, there's sort of space for all of this to exist so that we can support individuals in whatever way they would like to be supported. There's one thing that each of you would like to leave everyone here with around peer support and Warmlines. What would that be? And Howard, I'll start with you.
I'm sorry, repeat the question.
Maybe one thing that you'd like to leave the audience with around Warmlines and peer support?
Sure. I mean, the takeaway is, we're not trying to compete with crisis lines. We're adjunctive, providing a much needed service that since people really prefer talking to a peer, and we're really trying to build awareness of the existence of Warmlines and container funding to continue in our mission of serving people in crisis. Different training models, different Warmlines. Some operators have different tolerance levels to what they handle when they're having a suicidal line. I know you showed a brief clip of the David Romney, Oregon line just before the jam, and they can take a caller that may even have means handy and ready and talk them down and avoid it and do very well with that. So then we have some other operators that just feel like the person is too suicidal for them to help, and they really feel they need a crisis intervention. But we do try to avoid that. We do have some volunteers calling all of our Warmlines on our warmline.org directory to verify that they are true to the model, that they are peer specialists, and that their hours of operation, verify that information. And we are trying to collect information like that on, would this Warmline ever connect somebody to 911?
Thank you. Yeah, thanks for that, Howard. Kimberly and Trenda, maybe 30 seconds each on something that you'd leave folks here with.
I'm just going to focus on my passion is suicide prevention for personal reasons. Warmlines do so much, and I don't always call when I'm suicidal, but you can, and like some lines handle it better than others or whatever, but they're always compassionate, and I think Warmlines save lives. I think that's the most important thing. There's so much that we do, or Warmlines do, but that for me is the strongest driver of my volunteering in this effort.
Yes, thank you. And how about you, Trenda? What would you like to leave us with?
Mm-hmm. I really can't stress enough that Warmlines operate from a peer model, which is a very different model than the rest of the system of care. It's not a clinical model. It's not a crisis model. It's not a medical model, right? It is a mutual and reciprocal model that shares power, that puts the person in a place of being able to make choices for themselves and use self-determination for how to define their own crisis or how to define their own experiences. We're not labeling or placing diagnoses or words on people's experiences, but just simply making space for them to define that for themselves. And then the last thing I'm going to say is we need data. Data.
Thank you. Thank you. I really appreciate the three of you joining us for this great featured presentation and roundtable. Again, of course, and if anyone wants to reach out, this whole presentation will be on talk.crisisnow.com. And so we're going to move forward. And
if anybody has more questions for Trenda or Kim, they can email me and I'll pass them along.
Awesome. Thank you, Howard, please. And then you can put that in the chat. I'm going to bring up Tiffany Russell from SAMHSA, a great friend of the jam here, and she's going to give us a SAMHSA update.
Thank you, Laura. So good to see you. Hi, I'm Tiffany Russell with the 988 and Behavioral Health Crisis Coordinating Office, and I'm here today to provide updates for today's Crisis Jam. So today's presentation, the featured presentation, is a great wrap up for September as National Suicide Prevention and National Recovery Month. So thank you, Howard, for all of the great information on Warmlines and peers that you shared just moments ago. Laura also mentioned earlier in the call that we've recently just celebrated our first annual 988 Day on September 8th. And 988 Day garnered a total potential reach exceeding 150 million across social media platforms. So you guys did a great job, and we're excited to see what comes up for next year. I'm sure you've all heard about this now, but again, this has been a great month for us here in the 988 office. But 988 geo routing is now active for T-Mobile and Verizon as of Tuesday, September 17th. And with just those two major carriers, that covers at least half of our network's call volume. And so we're going to continue to work with other major carriers and some of the next tier carriers to get geo routing to be active. But we're super excited about having that completed this month as well. Most of our SAMHSA leadership today is they're participating in a 6-state policy academy with ACL and the Link Center that aims to support participating states, territories, and tribes to ensure capacity and relationships sufficient to support children and adults with IDD, brain injury, and other cognitive and communication differences who need 988 and other crisis response. This particular policy academy is helping 6 states to develop resources as well as standard operating strategies to ensure an inclusive, accessible 988 lifeline and crisis response system. So we're super excited to be doing that today. Also just wanted to mention this, if you didn't know, last week we released the Connected and Strong Technical Assistant Briefs to foster unity and strengthen continuity across the crisis response and treatment systems. This is a series of 10 papers that focus on various issues around implementing a connected and strong, comprehensive and effective behavioral health crisis system. And one of those topics for one of those papers is about leveraging strengths and leveraging strengths and opportunities of 988 and 911. So thank you, Dr. Brian Hepburn and Dr. Deb Pinels for helping SAMHSA get all of those papers out and for all of their hard work in producing those resources. I can also drop a link in the chat if you would like to see any of those 10 papers. Speaking of 988 and 911, the NINA standard for 911 and 988 interactions is inching its way towards completion. The second round of review for public review and comment closed on Monday of this week. And we hope that this means that we are getting closer to having that standard out for supporting 911 PSAPs across the country in their interactions with 988 network centers. So we're super excited about that as well. SAMHSA additionally has a lot of publications in production. One of those being a 988 and 911 collaboration risk and liability toolkit. This is a follow-up resource to our 6th series Connecting to Serve webinar series on 988 and 911 collaboration. So now that we finished those 6 episodes, they are available on our TTAC website. This toolkit on risk and liability will follow the 2 last episodes, which were only on risk and liability. So hopefully that information that was provided in those webinar episodes will tide you over until we get that toolkit out and about for everyone. We're also working on guidance on when to call 988 versus when to call 911. And we hope that that actual resource tool will be available before the end of the year. So really excited about that getting out there as well. And before I turn it back over to Laura, I want to talk very briefly about upcoming events that we do have coming up so that you can put this on your calendar. 988 Call for the Culture is a national HBCU initiative to prevent suicide enhance mental health, wellness and resilience, and increase diversity in the crisis care workforce within the African American community. So we're super excited about this initiative. And in order to get ready for that, we will be hosting 2 national webinars. The first one being for HBCU students, which will take place on Thursday, October 24th. The first one is at 11:30 a.m. and the second one is at 4 p.m. Both of those are Eastern Standard Time. And then we'll also have a separate webinar for campus administrators, faculty, and staff on Thursday, October 17th at 12 p.m. Eastern Standard Time as well. Happy to share the QR codes and sign up registration for those as well. But please share the message about 988 Call for the Culture. And lastly, before I turn this back over, even though she's not here today, she's actually at the Policy Academy. I want to send a very, very happy birthday to Dr. Belina Shaw with the Centers for Mental Health Services here at SAMHSA. It is her birthday today. Thanks, Laura.
Thanks, Tiffany. Lots of things happening with SAMHSA. So thank you for all of your leadership that you and the entire coordinating office provides. I know from John Palmieri to Monica to James, the entire team is just fantastic. So thank you all for what you do. And happy birthday, Dr. Shaw. She is fantastic. And we all know her from the jam, right? Because she was critical in writing the youth crisis services paper. So we'll have to have her come back and we'll have to give her a happy birthday in person. Tiffany, you mentioned a lot of papers coming out in partnership with NASHBID. Again, the National Association for State Mental Health Program Directors do wonderful work, particularly with the state. So I'm going to bring up NASHBID, and from NASHBID, we have Jessica Pollard, or Dr. Pollard, I should say, who is the Senior Behavioral Health Advisor there.
Really only my parents like to call me Dr. Pollard, but whichever you prefer. And that was a great segue, Laura. So I had to start my timer because I have no idea how I'm going to fit this entire update into just a few minutes. What I'll talk about from NASHBID today is how a few of us from NASHBID attended the Digital Mental Health International Congress in Ottawa, Canada's capital, last week. There were 29 countries represented at the Congress. And what do we mean by digital mental health? What exactly were we talking about? It's anything ranging from digital or online self-help tools to telehealth to digital therapeutics. They can be completely digital resources or human-supported resources. And really with the goal of increasing access to supports across a range from population well-being all the way to acute care, crisis care, and supports for people with serious and persistent mental illness. And so why should we care about this? Why is it interesting? I can pick just a few reasons in my time. We know we have workforce challenges, and even if we could magically increase the number of behavioral health workforce overnight, we know that some people, based on research, actually prefer digital tools or e-mental health resources because they like the anonymity, the lack of judgment, the less stigmatizing approach for some people. And it can feel available 24/7, or it can be available 24/7. So lots of reasons why people may actually have a preference for digital mental health resources, even beyond lack of access. So we know there are youth are online, and that's a area where we need to be also in the mental health and substance use space if we're going to be helpful. We also, one of the good quotes from the conference, we don't want to be cringe. So we have to make sure our digital mental health tools are really designed, as they all should be, with user engagement and co-creation. So that was a big theme of the conference. And it's not enough to increase access. We also need to be thinking about digital mental health literacy, both from a user standpoint and from a provider standpoint. We don't often get trained in this, either as healthcare providers or as people who might use the services. So there's some great resources that were described at the Congress on how do we increase digital mental health literacy. And to make sure I shout out at least one concrete resource, at Harvard, the Beth Israel Deaconess Medical Center's digital psychiatry program has some great information around mental health literacy and how to increase mental health literacy, digital mental health literacy specifically, as does the EMHIC or EMIC, the E-Mental Health International Congress. So I'm going to put some links in the chat for people. And I want to mention also, I said, why should we care about this? There's a lot out there and people are using it. And so it's important, I think, for us to get on board and be aware of how these resources can be helpful, as well as how they can present risks and be harmful so that we can productively participate in the discussion and think about how to use them from a system improvement standpoint as well. There was a quote from one of the presenters about, we're standing on the shore and there's a tsunami coming. And so we have a little bit, but not a lot of time to prepare and to be thinking about how we want to meaningfully integrate and kind of get out. I say get out ahead, but people are really already using these tools. So I think we had a recent debate, or maybe not recent, but there was one of the Crisis Jam debates was about AI, yay or nay. And I thought it was really interesting that one of the recent studies presented at the conference was talking about how even when these tools are not necessarily designed to be a mental health tool, like a lot of the Chat GPT resources, people are using them as a means of emotional support, even if it's not marketed or designed that way. People are engaging with Chat GPT to get help or to get empathy and understanding and advice. So it behooves us to make sure we're part of that process. So there are lots and lots of examples. I didn't give myself enough time to talk about them all, but just to say that these can be great tools to predict things like recurrence of substance use or a pending episode of psychosis. So we saw some great studies, like 90% sensitivity and specificity to predict an episode of psychosis in the next few weeks or an upcoming crisis, which can really help us deploy our limited resources to where people may need them the most. So a lot more I could have said, but somehow 5 minutes has gone by already, and I see Laura popping up, so I will turn it back over.
Thanks, Jessica. I think we will have a link in the chat if we haven't placed it already to a lot of those papers. But again, folks, NASHBID is just such a wealth of experts and work. So make sure that you're connecting with them if you're not. But I am going to bring up next Stephanie Hepburn to talk about the latest Crisis Talk article. Stephanie?
Thanks, Laura. So I'm going to bring on Stephanie Greer. She's a neuroscientist and product manager director at Doro Mind. Stephanie, in this week's op-ed, you talked about society's reluctance to talk about psychosis. Can you talk about the impact?
Yeah, I think that, this is a group that loves to talk about mental health and hopefully a really wide range of topics, including psychosis. But I still feel that it is one of the least talked about elements of mental health. And to talk about it a little bit, psychosis is a symptom. It can be accompanied with a range of diagnoses, but clearly it's the hallmark of things like schizophrenia, schizoaffective disorder, and then also a major part of bipolar 1 disorder, which is something that my mom struggled with and still, lives with today. So that's some of where my perspective comes from, seeing this both as a child. So for me, learning about psychosis, not formally, not using that language, but learning about it from, my earliest memories, but then also seeing my mom, go through bouts and then over the course of about 8 years, learn to live well and to get treatment. And so I've also seen her recover and live a very normal life. And that's what I wanted to share and talk about in the op-ed here to, remind people that there's kind of a whole life and a whole trajectory with psychosis.
And you talked about some of the steps that mental health professionals can, you said often like the stigma and not wanting to talk about it is so pervasive. It's not just in society, but it's also in the mental health field. And that it sounds like your mom's experience was very different, but that you continue to see this idea that recovery is not possible. Can you talk a little bit about with your mom what was different and what you suggest for participants listening right now?
Yeah, I think that so I hear that from so I've gone on to kind of work in this area. I started a program for families who have loved ones with serious mental illness, and then I have also interviewed a range of people living with mental health challenges, including psychosis and schizophrenia and bipolar disorder. I've also, talked in and worked with a lot of people in kind of the mental health professional field. And what I hear from the people with lived experience is often they're told that they're given a very hopeless message in the beginning of their journey. I had an interview with a woman named Michelle Hammer, who has a clothing brand around schizophrenia and is an advocate and lives with it herself. She said the first time one of the first times in the office, she got handed a pamphlet that had a woman crying on the front. And this was like her introduction to schizophrenia and kind of what messages are coming from the professional field there for folks. Things are changing over time, and I think people are becoming more aware of early intervention. But even as I talk to health professionals, they are often lacking training in serious mental illness because maybe their training's been focused on another area, which makes a lot of sense. There's a lot to cover in mental health. Not everyone's going to have expertise in everything. But people come to, whoever they come to around mental health, and often people don't understand that there's really a range of outcomes and, different ways that things can go with psychosis. And there are kind of treatment options and early intervention options for people living with psychosis. So I still hear that from mental health professionals as well. I don't know that my mom's, story was really different. I think that she was hospitalized several times. She attempted suicide when I was about 9. And I really feel like there could have been, better support earlier in her journey. It was at least 8 years of a lot of ups and downs. The average time now for people to get help is about 11 years. These journeys are really tough and long. And I think that more awareness and more understanding of the different ways that people live with psychosis could really help us do better and improve the system.
Well, thank you so much, Stephanie. And this op-ed is fantastic. I'll pass it back to you, Laura.
Thank you so much. I really appreciate it.
Thank you, Stephanie and Stephanie. Appreciate that. And, again, you're getting some kudos in the chat here. It is a conversation I think folks are really wanting to have. And again, that helps us destigmatize talking about mental health or destigmatize mental health and crises because we are just simply talking about it. So thank you for that. Okay, let's move forward because this has been great. But we have even more great stuff coming for you all next week. So on episode 192, we will have Zach Imel, who will talk to us about technology supporting developing a human-centered workforce, which has come up already a little bit today. And then I think we have a sneak preview of the week after that. Yes, that's right. And we've got David DeVorce, and I'm sorry, David, I've just butchered your name, but he will be talking about CCBHCs, which are certified community behavioral health clinics, and the crisis response. Again, a very important component of serving individuals. Looking forward to in December, we will have another debate. So you all may remember the first debate with John Draper around AI. Debate number 2 is going to be crisis peers. Again, another conversation that we've had today with Ara Foster and Dr. Renee Keed and Dr. Ursula Whiteside. So look forward to that coming in December. Please join us next week. Thank you for watching. Have a great day, everyone.